A qualitative study that was published in the Journal of Hemophilia in 2011, speaking to the fact that some women still, in particular women carrying the gene of hemophilia, experienced some negative had some negative experiences, either due to the inappropriate care as they perceived, or some dismissive attitudes encountered, even in the hemophilia treatment centers. So I think we're not quite where we need to be yet, and part of the reason for having this session is to exchange on different aspects, also different models, and to see how we can do better moving forward. So I just want to mention that we have a group of panelists, and thank you in advance for agreeing to participate today. For those of you that don't already know me, I'm the hematologist and medical director of the women's program at St. Justine Hospital, Montreal. David Page is the national director of health policy at the Canadian Hemophilia Society. Michelle SHOLZBERG, sitting next to me, hematologist and the medical director of the coagulation laboratory at St. Michael's Hospital, University of Toronto. Catherine TAILLEFER is an obstetrician gynecologist whose main practice is in high-risk pregnancy. She's not only the main consultant, but she's the co-director of the women bleeding disorders at St. Justine, along with me. Lisa is the hemophilia nurse coordinator of Southeastern Ontario Regional Inherited Bleeding Disorder Program in Kingston. And Nicole Warren is the physiotherapist at St. Paul's Hospital in Vancouver. I won't read the short themes that we're going to be discussing. I've asked all of them to tackle a small theme in addition to telling us how their center works, so that we can get a flavor for how the different teams function, but also to touch on some key aspects of how to make a hemophilia treatment center the best that we can. So without further delay, I'm going to hand it over to David.
So the planning committee for this meeting decided several months ago we'd like to get an idea of what the big picture is in terms of services for women with bleeding disorders across Canada. We don't really know in terms of how different centers are set up. We know about some of them, but not all of them. And so we developed a very simple survey, and the survey was distributed by Lisa. I don't know why I'm doing this, but I am. The survey was distributed, the data collected, and the presentation prepared by Lisa, but somehow she twisted my arm to come and do it. So if there's any problems, you need to ask the questions to Lisa. So the survey was circulated to all the hemophilia nurse coordinators in the 26 comprehensive care centers. 17 of the centers responded, representing 65%, and there were 9 questions. The first question was asking about what best describes healthcare delivery models for women with bleeding disorders in their centers, and then we gave them different options. Regular WBD clinics, which included an OBGYN. D was they're seen in regular hemostasis clinics with men and women by a team that does not include an OBGYN. They're referred to an OBGYN in the hospital, in the same hospital, or referred to elsewhere in the community. So these were the answers. Model E was referral to an OBGYN with close collaboration with the comprehensive care team, and that represented about 40% of the centers. Model D was the second most common, with regular women and bleeding disorder clinic, but no OBGYN. And about 20% had a regular women and bleeding disorder clinic with an OBGYN. So that's about 20% represents a fifth of the 16, so probably only three clinics. We asked them about which disciplines make up the team, and this is sort of somewhat predictable, but only 50% have an OBGYN. And only maybe one center has a anesthetist. In terms of the coagulation tests and the lab, it was estimated that 80% of the clinics are able to do all the necessary tests for women and girls with bleeding disorders, and 20% are not in a position to do that. I think we have responsible for maybe about 12 of the centers in terms of the number of women who are treated, women and girls who are treated. And you can see that it ranges anywhere from about 10 up to St. Justine, which is 800. So a huge variation in the number of women who are registered. We didn't have answers from all of the centers in terms of the numbers. Is it an established priority? 88% said that was an established priority among those 17 centers that responded. 94% responded that they felt that bleeding disorders were adequately managed in their centers. 88% responded that they feel that the comprehensive care clinic has improved patient care and quality of life, but 12% said no. And these are some of the barriers. By the way, all these presentations will be on the CHS website eventually with the slides, so you don't have to take copious notes. But clearly the first item here was no dedicated OBGYN. Resources. Patients living in remote rural areas. Not all members of the health care team present. I'm sure you recognize a lot of these issues and the barriers. And finally, the last question was, what other information would you like to report? And there's a wide variety of answers to that question. And now I'll put Lisa on the spot. Anything you'd like to add?
Does this work? Yeah. Okay. Some people did mention for team members, like they had access to anesthesia. They weren't on the team, but they had easy access to anesthesia or psychologists or like had access to a social worker if they didn't have a point one within their clinic or something like that. So they'd written little notes on this side that they do have access to them, but not directly on the team.
So I guess if any of you are here from the 9 centers that did not report, I'm sure we could still collect that information and make it more complete in the weeks to come. And that's we move on to the next one.
I don't know if there's any quick comment or question just before we move on. We'll open up the discussion at the end anyway, but one of the things that I find concerning is that there is a lack of psychological support in many of the clinics, including our own. We had a dedicated psychologist who was our hemophilia person, but she saw all the women, Suzanne, I'm looking at the nurse coordinators of the clinic at St. Justine, and we had a very dear colleague who took her retirement. But we had the support a little bit at one point, and we don't anymore. And it's a very, very big part missing from the clinic, no question. Michelle?
Hi, everyone. So I was asked to present on what it takes to develop a multidisciplinary clinic in this day and age with the idea of a focus on patient empowerment. So we developed the multidisciplinary team in early 2014, and we launched our first clinic in July 2014. And so our core team includes our nurse coordinator, Georgina Floros, our administrative staff, who's Antoinette Travis, our lab technologist, so we notify our lab technology team of any woman who's going to deliver, so that they expect that a cord blood sample might be coming as well, and they know to run its stat, as well as to run the level stat on the woman. We have our research team, so we always have at least a research assistant and often our research program manager present in our multidisciplinary clinic, which occurs monthly. We have access to our physiotherapist and our social worker, of course. And our extended team that is multidisciplinary includes myself as the adult hematologist, so I take care of the mom. We have an OBGYN, Philomena Meffy, who's the chief of OBGYN at St. Mike's. We have a pediatric hematologist, Jillian Baker, who also is a neonatal intensivist. So it's like amazing. And we also have an anesthesiologist, Rachel Martin, who is the head of OB anesthesia at our hospital. So I recognize that I'm particularly fortunate to have these team members, and I do think that there's also, to be honest, added value in it being an all-female team, because our patients feel really comfortable talking about vaginal bleeding and etc. So we developed the vision and the plan. This is something that Georgina and I developed early in 2013. We needed to get commitment from all these various staff members and get hospital support We met with finance, scheduling, the scheduling team, logistics, etc. We had to develop a patient flow template because you can imagine running a clinic with 4 separate physicians is really challenging. And so it all falls on the organization of Georgina, and she directs us to each room and makes sure that patients are in and out as quickly as possible. And we always have a pre-clinic meeting. So before our clinic starts at 9 a.m., we always meet at 8:15 in the morning, and we discuss all the patients that we're going to see. One thing that was critical for us is that before we actually launched the clinic, we went and visited the Kingston Clinic. And that was really helpful because we got some key pearls from Paula and her team. One of the things that was really important for us to hear is that never schedule a new patient that is new to both the hematologist and the obstetrician the same visit. And that was really important because things really slow down when neither one of us know the patient. So we always try to ensure that at least one of us knows the patient well before. Another thing that we did at the onset of our clinic is we started a database. So there's a research database that collects information on the patients that flow through our clinics. We also developed a logo, and we thought that that was important just for branding of our clinic and sort of a sense of unity and to enhance our mission. So since July 2014, we've seen 249 women. It's a total of 180 clinic hours. 94 babies have been born, and 9 of those babies are diagnosed with a bleeding disorder. So each clinic, there are about 10 to 12 patients that are seen by, sorry, this is wrong. I don't know why the formatting got strange, but I see, oh, okay, it's no problem. I see the majority of the patients. I see 10 to 12 patients. About 8 or 9 of those patients, there's overlap with the obstetrician gynecologist, and there's overlap with our anesthesiologist and pediatric hematologist for about 2 to 3 of those patients. So our anesthesiologists and pediatricians see less patients than myself and Dr. Murphy, because remember, we're not just seeing the women who are pregnant, we're also seeing women with heavy menstrual bleeding, etc. And so Philomena and I have to move quickly in clinic. Now, in terms of a focus on empowerment, so the 4 of us, actually the 5 of us, including Georgina, feel very strongly that our patients need to be at the center of their care. And so we develop a treatment plan for all of our patients, and it looks like this. I know you can't see it. But it starts off with the woman's name, the diagnosis, the chances that the baby might be affected. And then it says obstetrical care for the mother, anesthesia care for the mother. So there's like subheadings, and then it says hematologic care for the mother, and then at the bottom it's hematologic care for the baby. And then from a nursing perspective, the second sheet is if, let's say, the woman needs to receive von Willebrand factor containing concentrate, it actually gives specific for our nursing colleagues, which are going to be the OB-GYN nurses, it tells them how to reconstitute the product and etc. So Georgina has spent endless hours teaching on the OB-GYN floor, making sure that they feel comfortable giving tranexamic acid, making sure that they feel comfortable giving factor concentrate. And so we provide the patient herself with a copy of the treatment plan. And that's number one, so she feels empowered and she's aware of all the steps and everything that's going to happen on the day of her delivery. And also in case she doesn't make it to St. Mike's, so that she arrives at, I don't know, at like Humber River Hospital and says, this is my care plan, and all their phone numbers are at the bottom. So we want to ensure that she's well informed, that she's in control, that she knows how to self-advocate. So we tell all of our patients straight up, nobody's going to have a clue at any other hospital what a hemophilia carrier means, what von Willebrand disease is. They'll have no idea. You show them this and you say that you and your baby are at risk of dying if they don't follow this. And I say be dramatic and make sure that people follow, because we need to make sure that the treating clinicians are scared of her and the baby and will act fast. We also feel that it's important for our patients to have opportunities to engage in education and quality improvement related activities, and also in research opportunities to advance her own care and possibly, ideally, the care of others. And so that's the multidisciplinary database that we developed. And we also developed an educational tool on the use of tranexamic acid after childbirth, because we felt that After birth, the mother is completely, disorganized naturally and focusing entirely on her baby and not on her own health. And so this tells her how to take tranexamic acid appropriately postpartum. And it even talks about hemorrhoidal bleeding and stuff and when to contact us. And then these are just some examples of studies that we have open at the moment or very soon. And you'll recognize the sister study. We have a bone health and symptomatic carriers of hemophilia A that's going to open up. We have a pregnancy loss and BWD multi-center study that's open. We have a knowledge translation study in postpartum hemorrhage. And then we have our database that's ongoing. That's our clip.
So now this is a model that many of us could be jealous of. I just want to start off a little bit of a comment before we go to the next speaker and saying that, the vision for the Women Bleeding Disorder Clinic, I don't know which is the first in Canada. I know that Dr. Rivard had a vision early on of the women's needs being different than in hemophilia in 1999 and started the first Women Bleeding Disorder Clinic at Saint Justine in those years. And one of the troubles that they came across in trying to set it up, which was a bit what we wanted to address here, was that people that weren't identified weren't committed. So in other words, if there's not you are assigned to be the obstetrician that's in charge of this clinic, it's almost like the other person's going to do it. And what ends up happening is that it doesn't happen. This experience happened repeatedly in clinics trying to develop in New Brunswick that came to visit us. And the problem is that we realized that the people weren't identifying the team player that needs to really go with it. And at that time, it was Diane Francoeur, who was the co-director of the Women's Bleeding Disorder Clinic at Saint Justine, and they started off with sessions on education. So the obstetrician was educating the hematologist and vice versa until the clinic was put onto its feet in 1999. And so I think one of the key things is to say you're in charge, and it's me, and it's you, and it's that person, and then there's a sense of responsibility, and then things can take off from there. And the other comment is, things can expand gradually. It doesn't all have to start with this huge team right away. It can start with what I call the core team, and then you can build on it depending on resources and depending on what's available to you in your center. So those were the comments I wanted to make right away before we continue. Are there any burning comments, or should we continue and then open up discussion?
And actually, just to your point,
Yeah.
it's actually really important to have clear buy-in and
Absolutely.
identification of the team members, because, it required, like Philomena Murphy, to give up one of her other clinics
Right.
to join this one, right? And so
Now Catherine
that's a big
and
thing,
Claudine.
yeah. So it's a lot of dedication for people that are not necessarily well-versed in inherited bleeding disorders to start.
Okay, so we're going to go to the next speaker, and then we're going to open up the discussion. Who was the next speaker? It's Catherine. So Catherine is the co-director of the Women's Multidisciplinary Program at Saint Justine, along with me, and the clinical hemophilia nurses that take care of the women are sitting here, Catherine Thibault and Claudine Amess, who are in charge as nurse coordinators of the clinic.
Thanks for inviting me. And at first, when I saw this subject, wanting me to talk about the virtual multidisciplinary clinic, I thought we wanted me to talk about like Skype consultations and people down in the north. But no, it's really in fact the reality of our clinic. As we told you in St. Justin Hospital, we have a lot of women registered to this clinic, and we are getting a big team. I put a pregnant woman in center of this team, and sorry, this slide is really small and the words are really written small because we're a lot. And I should have put in the middle of the picture a baby, a small girl, a woman, not pregnant, an aging woman, because we all follow these women within these different moments of their life that may be problematic when they have a bleeding disorder. So we work really in a team with designated people, with hematologists, with the nurse coordinator, with me, with an obstetrician trained in MFM. We have also gynecologists, mainly trained in pediatric gynecology, but generalist gynecologists too. Pediatrician, we have 2 anesthesiologists, we have the labs, the geneticists, some other people that come more if we ask for a consultation. So this is our model, the model with which we want to work and accompany women. But here's our reality. This is a sky view of St. Justin Hospital. And I don't know if we can see the mouse here. This is the older part, and this is the new part that was built in 2017. And the reality is that the hematology department is there, the lab is there, the MFM is there, the delivery room is there, the radiology unit is there, and the OR is there. And the distance you can walk between each of the end of the hospital is about almost 1 kilometer, and you can walk like 10 kilometers a day when you walk back and forth in the hospital during that day. So this is a reality for the clinicians, but this is also the reality for the patients that going to walk through this department. So this is what it means, the virtual clinic, in that sense of our clinic. So when the patient come to visit us, they do not come in one specific place meeting all the consultants. They have to move from one to the other one in the hospital. There are some advantage of this situation. We might think, like, let's say when I'm doing my high-risk pregnancy clinic oriented in hematology, sometimes women with bleeding disorder might be a third or a quarter of my clientele in this clinic. So I might be more efficient seeing more people and have a better utilization of my time seeing more people. I think the biggest reason to do this is for administrative costs that might be lower because we're using the setting of the regular clinic in the hospital. The clientele is integrated in every clinic, so it kind of normalize their status. They're kind of the regular clientele, so it may be interesting for them. And it's good to stay fit, to walk like this, which is a good thing during pregnancy. But it's a lot of time for the patient, and we're not always on time, so they might have a lot of waiting in the different clinics and the different waiting room. And we should say it might be hard for us to communicate between each other. It's not direct. We have to phone. We have to try to reach the other people with the smartphone. It might be a little bit easier. And the coordination of care might be a little bit harder, and we have to be creative in the way we organize our care for this woman. What we founded for solution were our multidisciplinary meetings that we do all together. We will plan to talk about the situation of women who need to have more planification, and then we're able to do a therapeutic planning, really quite the same that Michelle described, that will write for every patient either before a delivery or before a surgery or before any other intervention, and there will be a resume in the chart. That is, the chart is informatic, and the woman will receive a copy of her resume too, so if she go to another hospital, she will have the information. Sometimes we add more complicated patient, like this winter. We talked a little bit this morning about a woman with von Willebrand type 3 that was living far away from the hospital, that was not speaking French or English. So we just fixed for her multidisciplinary appointment with someone that can traduce to her, and it was really helpful in that kind of situation. So this will plan it momentaneously. And we use a lot for communication by mail, by SMS, by phone. We talk a lot, many times a day between each other, just to be sure everything is well coordinated. So this is how we face this big challenge of the virtual clinic. But as the title said, in the title, I don't know if you remember, it was finished by will it stand the test of time? And we'll maybe meet in a couple of years just to tell you if we were able to continue like that or if we were able to change to have a concrete clinic. Thanks.
Any comments? Nothing? Go ahead.
Hi, everyone. So I'm Lisa from Kingston, and I'm the nurse coordinator there. I was asked to discuss the challenging role of the nurse coordinator, the clinic and beyond. So I won't touch on the models as much. I know we're a little bit short for time. Ours is similar, definitely, in Kingston, of how we run our women and bleeding disorders clinic. But what I wanted to highlight is what and all the nurse coordinators in the room can attest to, of what we actually do in our role and in our job. This slide should have been first, because it is patient-centered care, and at the middle of everything we do is the patient. But with managing a patient comes dealing with all of these people. So I just wanted to give you a few examples of what we do. So some of us deal with multiple hematologists, so adult and pediatric at my clinic. Definitely the special coagulation labs, whether they're on-site, off-site, we have to plan around the ORs and the availability of staff within the special coagulation lab. So that means booking our ORs at the beginning of the week so that we can have the proper staff, because they don't work on the weekends unless it's an urgent situation. The blood bank, so being Arlen is Oshawa to Cornwall, so organizing all the blood banks wherever any of our patients are and making sure that they have enough product, that they have emergency doses for every one of our patients in that area. And every blood bank has differing comfort levels with products. So if we had someone having surgery in Brockville, that blood bank may be comfortable reconstituting and sending up the product to day surgery, but in Belleville they might not be. So then I have to educate the nurses in the day unit on how to do that. So that's a piece with the blood bank. Surgeons, as we know, are fun to deal with sometimes, and are at multiple sites, different personalities, different comfort levels with our products as well. And I think my biggest goal as a nurse coordinator is to keep the patient close to their home, like close to their family, close to their city. So as soon as someone tells me that they can't have their surgery in Coburg, well, I take that on as a challenge because they can, and we can get them through everything safely, and that's my role. So it is a lot of coordinating, but it's worth it for the patient to be close to their support system. Genetics, not everybody has a genetic lab, so obviously we do. And the turnaround times for urgent issues, it can be challenging. Family physicians, so the patient may or may not have family physicians, they may or may not be engaged. So there's a lot of education on that piece, which we heard about this morning, and I think we need to do more. Maybe as a nursing group, we need to take this on to re-educate or do something within the community with GPs again. Physio, not all of them are attached to our clinics. If they are, sometimes they're only a 0.1 up to a 1.0, so it just depends your accessibility to physio and coordinating that. So then what are you doing? Are you getting help from your physiotherapist to then get the patient out into the community for physio that way? CHS is part of our role as well, so coordinating membership, and the request just came yesterday to help with that, so we'll be working on that. Hemophilia Ontario, we all volunteer, whether it's for camps or committees that are connected to Hemophilia Ontario. In Ontario, we're also highly involved with the redistribution program that Sarah Krimble runs out of St. Mike's, so that we don't waste factors. So she's instrumental in making sure, I forget what she said at World, how many units were saved, but millions.
3 million.
3 million? Yes. Dentists, we work with the dentists very closely. Again, their comfort level is very different, so if we can help them get through their concerns and worries about a bleeding disorders patient having a procedure done, then that patient can stay with their original dentist and not have to come to the hospital dentist. Again, outlying hospitals that have the ORs happening, arranging infusions, dealing with same-day admission centers, post-anesthetic care units, the levels that are required as soon as a patient comes out. We're usually responsible for checking them and being in touch with the hematologist. Pharmaceuticals coming to visit us a lot, and dealing with all of the home care programs that are attached to each product. So they all work very differently. Yeah. That's it. I think I covered everything. Oh, gynecologist, sorry. Dr. Jameson's here somewhere. Very lucky to have her. That's all fine.
Sorry, we started a little late and now we're a bit short on time.
I'm wondering why she didn't categorize me as a surgeon.
Because you're not hard to work.
So go ahead.
Yes.
All right. I'm kind of different as well. I'm not really talking about our clinics. Okay, I'll go quickly. I'm Nicole. I'm one of the physiotherapists. Today, I just want to discuss quickly the role of physiotherapy within the multidisciplinary clinic for treating women. In general, and our clinic included, I don't think physio really plays a large role in treating women with bleeding disorders, but I don't think that in any way accurately displays the need for physio input. I think there are lots of issues that we could have a role in, and I think that we're really missing something right now. So currently we treat patients if we're specifically consulted by the nurse practitioner, physician, or nurse. And in most clinics, we don't play a regular active role and are usually not present during the clinic time. So due to this model, I think we risk missing potential treatable issues. And we're not kind of building that rapport and the relationship that we build with our male hemophilia patients. And I'm kind of speaking from my own perspective, but I think that a lot of physios feel that way. So at this time, we're treating acute bleeds, musculoskeletal issues. We're giving general activity and exercise education. And this is great, and it's a large part of our role. But again, as I said, I think we're missing something. So we know that there are lots of treatment gaps, and during this session, I just wanted to touch on one that I think the role of physiotherapy could kind of transform in coming years. So I think we all know that this is an underserviced and under-researched population, and one could argue that it's kind of difficult to advocate or even know what the physiotherapy gaps are until we start treating this population more regularly. I'm interested in women's health and specifically pelvic floor physiotherapy. And I think this could be a really interesting way to bring physio to the women clinics. We know that they have more complications with pregnancy, and this could potentially lead to more pelvic floor dysfunction. I want to make clear that I'm not saying that that they do have a higher risk of that, because we don't know that yet. But I think it's something definitely worth exploring. So I'm kind of going to skip through what pelvic floor dysfunction is because of time, but these issues can lead to the need for surgical intervention if they progress. They also have a major financial impact to the patient and the healthcare system. And they have an impact on quality of life and can lead to psychosocial issues such as increased risk of depression and anxiety. So coming back to physiotherapy, how do we get involved? Well, there's lots of evidence to show the effectiveness of physio treatment for treating incontinence, pelvic organ prolapse, and pelvic pain. And this could lead to a decreased need for surgeries in this population, potentially. And I think that's really important with the population that we know has an increased risk of bleeding. So we could be working towards more conservative treatment. We also know that with the elderly population, there's an increased prevalence of pelvic floor dysfunction, and I'm sure that within the population of women with bleeding disorders, that's no different. So in conclusion, in an ideal world with unlimited resources, I think it would be beneficial for these patients to be seen more regularly by a physiotherapist, including a pelvic floor physiotherapist, and I'd really advocate for that, especially in the elderly and the pre- and postnatal population. So I think there's a huge potential here to mitigate surgery risks and increase quality of life for our patients. So I just wanted to bring that forward. Do you think there's a need for pelvic floor physiotherapy?